We are going to get started with medical management for essential tremor with Dr. Jessica Feldman. Dr. Feldman graduated from Tulane University with a degree in biology and later graduated from Tulane School of Medicine. She completed her internship and neurology residency at the University of Pennsylvania. Dr. Feldman was given the Zaritsky Award for outstanding research by a resident. We also established the program for neurology residents to rotate at a hospital in Botswana during the HIV/AIDS pandemic of the early 2000s. Dr. Feldman was in private practice in Bucks County from 2006 until 2021 when she joined the University of Pennsylvania. In 2023, she was awarded the Golden Apple Teaching Award for the Drexel Medical School and was then awarded the A.B. Baker National Teaching Award from the American Academy of Neurology. Dr. Feldman is a general neurologist with an interest in movement disorders, and she has a large practice of patients with brain stimulators. Dr. Feldman does both medical management as well as adjustment of stimulator devices. He currently has offices in Southport and Sellersville, Pennsylvania, as part of the Penn Medicine physician specialty practices.
Thank you very much. Good morning. Welcome. I hope this is educational, informational for you all. So I'm going to talk a little bit about medical management. And as you'll see, there's actually not a lot of great medical choices for essential tremor. It's fairly limited, which is why deep brain stimulation has become such a critical part of management for a lot of my patients. But we always start with medical management. So I'm going to start with a background there. And I'm going to talk a little bit just about essential tremor in general. So it's a neurology talk, so you can't get away from the basic science portion. So a little bit about genetics of essential tremor. So over 50% of cases are familial. However, the majority of the genes that are associated with essential tremor, we actually do not know what they are. We do know it's genetic, primarily because of the incidence in monozygous, so those are identical twins. So identical twins are twins where there's one egg that's been fertilized, one embryo that then splits. So those twins have identical genetic makeup. They have identical DNA essentially, unlike fraternal twins where there were actually two eggs that were fertilized, and they're closer to siblings than they are traditional twins if you think about it from a genetic standpoint. But the incidence is about 90% in identical twins. There's a couple genes that have been identified, ETM1, which is on chromosome 3, ETM2 on chromosome 2. But as I mentioned before, those are in smaller portions. One was in a group of Icelandic families, the other in a group of Czech families. The majority of the genes we still do not know. We do know that the majority of the time when it's genetic, it's autosomal dominant. So what that means is each parent has two chromosomes, and then you'll get one chromosome from each parent. And if you inherit the chromosome that has the essential tremor gene on it, then you will express that gene. Unlike a recessive where you have to have both of your chromosomes have to have that gene on it. In a dominant, you will express it. And there are varying ways that you'll express it. In some cases, it'll be what's called anticipation. So younger generations will express the gene at a younger age, or it can be a variable penetrance where your parents may have it and you may just have a very, very mild, one of your parents has it and you have a very mild case. So there is a broad range of which you can express the gene. So just briefly on essential tremor versus Parkinson's. So essential tremor is considered a benign condition, meaning that it's not associated with other neurologic features. It doesn't have a higher incidence of morbidity and mortality necessarily. Unlike Parkinson's, Parkinson's is neurodegenerative. Now, essential tremor can and will often get worse with age, but Parkinson's disease always gets worse over time. You have dying off of the cells that produce dopamine, and it is degenerative and is associated with a higher incidence of morbidity and mortality. Essential tremor, you primarily see that's your classic posture tremor. So when your hands are outstretched, or an action tremor when you do the finger to nose testing with your doctor, or when you're holding the coffee cup or the pen, versus the Parkinson's tremor is primarily the pill rolling tremor that you see at rest. Oftentimes that tremor you'll see more when patients are walking and their arms are just kind of resting where they're walking, and you'll see the tremor. The essential tremor primarily located in the arms, and then occasionally the nodding tremor in the head. You can also see it in the voice, the palate, the chin, versus Parkinson's is primarily in the arms, the legs, and occasionally a jaw tremor. As mentioned, it's benign. There are no other associated features with essential tremor versus Parkinson's disease. You'll see the classic cogwheel rigidity where you pull a patient's arm and it's like they're fighting back on you. Bradykinesia, so slowing down. You have them do the finger taps and one hand is tapping like this and the other is kind of doing this. Postural instability, so gait problems. And then with the essential tremor, the patients can oftentimes tell you their handwriting is messy versus Parkinson's disease. More classically, they'll get the messy handwriting, but they'll also get micrographia, the real teeny tiny handwriting. So just a few features that you can look for. So benign essential tremor is the most commonly seen tremor in patients over the age of 40, as Dr. Halpern had mentioned. It affects 5% of the general population versus Parkinson's disease. So Parkinson's disease, although young onset, certainly we see it, is more of a disease of the elderly. It typically affects patients over the age of 60. And even in that population, the incidence is only about 1%. Again, it more commonly affects the arms. It can start out unilateral, but it almost always affects both sides over time. Second most common affected area is the cranial musculature, the tongue, the head, the palate. Orthostatic tremor. So I'm only going to mention this because I talk about it a little bit in medical management. So this is considered a variant of the essential tremor. The orthostatic tremor is basically a tremor where when patients stand up, they develop this high frequency tremor in their legs and they feel like they can't walk. But once they start walking, they get better. So this is different than not being able to stand up because you're weak. And orthostasis, for those of you who are familiar with orthostatic hypotension, which is that drop in blood pressure when you stand up and you get lightheaded and dizzy, they're not connected. You don't have to have orthostatic hypotension to have orthostatic tremor. They're two different pathologies. And sometimes the orthostatic tremor is more of a feeling than an actual visualized tremor. But one way that doctors will diagnose it is that we'll put a stethoscope on our patient's calves and we can hear a classic whirling helicopter sound. And that's caused by a rapid muscle contraction in the legs when standing. But I do warn my patients before I do this, because I had one patient where I had put the stethoscope on their calf and I said, Doc, I think you got the stethoscope on the wrong place. I think you're supposed to have it on my chest. So I warn them why I'm doing it now. Just up here, I actually had a patient with this who there was an article in the New York Times Magazine. She couldn't stand without pain. What was wrong? So it was a patient that I shared with Dr. Tropea, who's a movement specialist down at Penn with orthostatic tremor. And this was a picture from the article. So alcohol in low doses can oftentimes suppress tremor temporarily. If you can get to a threshold where too much alcohol actually worsens it, but it can suppress tremor temporarily. And it's interesting because if you think of why alcohol works, you kind of get to the basis of why we think patients have essential tremor in terms of structurally in the brain. So there's a theory that the olivary nucleus, which is located in the brainstem, which is your involuntary center of the brain, is your central rhythm generator. And so alcohol can temporarily suppress those spontaneous rhythmic discharges that we think may be causing the tremor. Also, the cerebellum, which is your balance center of the brain, has granular cells which express GABA A, which is very sensitive to alcohol. Alcohol binds very tightly to GABA, and we'll talk about other drugs that bind to GABA, and so why we think this may help with tremor. Factors that can exacerbate essential tremor. My favorite coffee, I'm so glad I don't have an essential tremor myself, but fatigue. Extreme temperatures, extreme hot, extreme cold can oftentimes worsen it, emotional upset or heightened emotion, and then central nervous stimulants. And we'll talk a little bit about medications, but caffeine not being a medication classically will worsen essential tremor. So medications that can worsen it: lithium, used for bipolar disorder, neuroleptics. These are your antipsychotic, Seroquel, Abilify, some of those drugs, and then they are used sometimes for hallucinations and Parkinson's as well, but this is certainly they can worsen any tremor. Valproic acid, which is an anti-epileptic medication, tricyclic antidepressants, so amitriptyline, nortriptyline, used for depression, but also used for migraine prevention and for pain, antihistamines, Benadryl. Anticholinergics I bring up because this is Levsin for irritable bowel syndrome is a commonly used medication, and then Toviaz, oxybutynin, and Detrol for bladder issues are commonly used anticholinergics. Steroids, amphetamines, your ADHD drugs, Adderall, Ritalin, those can all worsen tremor. And then rarely SSRIs, SNRIs, your more classic antidepressants, Zoloft, Prozac can sometimes worsen the essential tremor. So now we'll get a little bit into medical management. So the most commonly used medication for essential tremor are beta blockers, and beta blockers were developed as blood pressure medications. Some studies suggest that there's about a 50 to 60% reduction with beta blockers. The most commonly used beta blocker is propranolol for essential tremor. Now, metoprolol is the most commonly used beta blocker for cardiac issues, and the reason is that propranolol acts on the beta-2 receptors, which are primarily found in your periphery. Your beta-1 receptors are primarily found in your cardiac system. So that's why cardiologists will oftentimes use beta blockers post-CHF or for hypertension, because you're targeting those beta-1 receptors, versus propranolol is found more in the periphery. And so that's why it acts better for essential tremor. Optimal dosage is 240 to 320 milligrams a day of propranolol, and that's a hefty dosage. Starting dosage for long acting is 60 milligrams. So sometimes getting your patient up to the dosage that actually works, they're not going to tolerate, especially if they don't have underlying high blood pressure. Metoprolol has to be dosed greater than 100 in most cases to see any effect on the peripheral beta-2 receptors. So that is a very big dosage of metoprolol. Starting dosages of metoprolol are generally 12.5 to 25 milligrams. So to get up to 100, again, you're going to see a lot of tolerability issues with that. We do know that if patients don't respond to propranolol, they're generally not going to respond to another beta blocker. And there are other beta blockers other than propranolol, metoprolol. There's atenolol, there's other ones, but those are the most two commonly used. Interesting, the long-acting preparation of propranolol is thought to be slightly better, or at least the same as the short-acting. The reason in my practice that I'll use short-acting is that because this is a blood pressure medication, it's going to drop patients' blood pressure. So if they're coming in with an essential tremor and they run low to begin with, their blood pressure is 100/70 in my office, I may worry that putting them on even 60 milligrams of propranolol is going to drop them too low. So I may start the short acting, because the long acting lowest dosage that it comes in is 60. So I may start the short acting because I can start 5 milligrams of that just to let their system get used to the beta blocker before I put them on the long acting. But I always tell them my eventual goal is to switch them to the long acting once we get to a tolerability from a tolerability standpoint. We don't actually know the exact mechanism of action of why these drugs work. So as with a lot of drugs, especially in the neurology literature, they were developed for one thing, and then the patients with some other neurologic condition came in and said, oh, it made me so much better. Classically, we see that with Botox, botulism, which we'll talk about a little bit later on. Common side effects. So because it's going to drop your blood pressure, it can cause dizziness if it drops your blood pressure too low. It also slows your heart rate, which is why metoprolol is commonly used after open heart surgery to keep those patients' heart rates nice and low. So patients who exercise a lot, especially runners and swimmers who are really trying to get their heart rate up when they're exercising, they will get shortness of breath sometimes with these meds, and sometimes they just feel horrible because they can't get their blood pressure up. So I'm careful when I use these with patients who run a lot. But I have a spin instructor who's been on propranolol for years, and she does fine. So she's really getting her heart rate up there, hopefully. It can exacerbate underlying asthma. It can occasionally cause weight, worsen depression, erectile dysfunction. Just a couple things to talk about. So primidone. So primidone, also known as misaline, was originally developed as an anti-seizure medication. In trials, it's been shown to have a 66% reduction in tremor at a dosage of 250 milligrams a day. So actually you'd say, well, this sounds better than propranolol. That was only about 50 to 60%, but it's much, much less well tolerated, and a lot of drug-drug interactions with primidone, unfortunately. So common side effects, dizziness and sedation is the one you see the most commonly. It can cause some ataxia, some unsteadiness and balance problems. It can cause nystagmus, which is where your eyes go back and forth, especially when you look in one direction, and that can make patients feel like they're moving, or it can make them have difficulty with vision. And then it can sometimes cause patients to feel like they're cognitively a little slower. They just don't feel as sharp. And in some cases, it can actually cause vertigo, which is that dizziness and spinning. Now, these are potential side effects. Not everybody's going to get them if they go on primidone. And I have plenty of patients who take upwards of 750 milligrams a day of this medication and are fine. But I always tell my patients, I'm not going to just give you a medication and say, oh, call me if you think you have a side effect. I go over everything you could potentially get so that you're aware, and then you let me know if you get it, but most people don't. And then the one other thing that I always counsel my patients with this medication especially, is that primidone is one of those medications that has first dose effect. So when patients first take it, usually within the first 2 to 3 days, they might feel terrible. But I tell them, if you can start it on a Friday and push through the weekend, by Monday, you should hopefully already start to be feeling a little bit better. Unlike there are some drugs where donepezil, for example, if you get diarrhea on that drug, you're done. You're probably never going to be able to stop the diarrhea until you come off the drug. This drug really, if you can push through those first couple days that are really uncomfortable, it does get better in a lot of cases. So, and I didn't put it up here, but unfortunately, as I mentioned before, this drug has a lot of drug-drug interactions, especially with your NOACs, your novel anticoagulants, so Eliquis, Xarelto, those drugs that are out and commonly used now. You can't use it with those. Interacts with a lot of other anti-seizure drugs. You have to be very careful with this medication. So that limits it as well. Benzodiazepines. So these are your drugs that were typically thought of more commonly as anti-anxiety drugs. So Xanax, Valium, lorazepam, diazepam, clonazepam, but we use them for a lot of other things. They're anti-seizure medications, and they are good tremor drugs. Clonazepam, which is the longest acting of those of this category of drugs, is generally considered to be the most effective, and it's the only one that helps that orthostatic tremor that I had mentioned before. Well, it's generally thought to be the only one. I do have one patient who uses diazepam, and it really has been helpful for her, but it's generally considered to be the only and most effective for orthostatic. Alprazolam is actually considered to be the second most effective medication for essential tremor in this class, and that's Xanax. But we don't know if it's more that it has an anti-anxiety benefit. And so, as I had mentioned before, essential tremor is worsened with high levels of stress and high levels of emotion. So calming that anxiety may be more of a benefit that you're seeing with the alprazolam. Alprazolam is your shortest acting of your benzodiazepines, as well as your highest potential for addiction. So the main side effects to these drugs, they don't have a lot of drug-drug interactions. You want to counsel your patients not to drink alcohol with them. But typically the biggest side effect you're going to see with benzodiazepines is just that they make patients really tired. But they can lead to dependency and addiction. So you have to be very careful, especially if you're treating someone younger with these medications. Gabapentin, again, developed as an anti-seizure drug, but we use it for, nowadays, we don't use gabapentin for seizure nearly as much as we use it more commonly for neuropathic pain. So pinched nerves in the neck and the back, diabetic neuropathy, and other forms of neuropathy. We use it a lot for migraine, and it is actually used for anxiety. So it's been shown to be effective in small studies. However, it does require high dosages to be effective. So starting dosage of gabapentin is usually 100 milligrams 3 times a day. Most studies suggest that you're not going to see a tremor benefit until you get closer to 400 milligrams 3 times a day. And the majority of the patients need between 1,800 and 600 and 3,600 milligrams. So that's a fairly hefty dosage of this medication. This medication has very prominent dose-dependent side effects. So the side effects with gabapentin almost always occur as you're increasing the dosage, which is why that's what really limits the use of it. Side effects: sedation, dizziness, weight gain, and you are going to see them as you increase the dosage. Topiramate, which is another anti-seizure drug, is in the carbonic anhydrase inhibitor family. Now, there are other carbonic anhydrase inhibitors, such as Diamox, that were used more traditionally, but we really don't use that anymore for essential tremor. So we know that this works by enhancing GABA. And as I had mentioned before, we know those cerebellar granular cells are especially responsive to GABA. So that's why we think some of these GABA acting drugs, again, benzodiazepines also act very strongly on GABA. Primidone acts on the GABA. Topiramate was developed as an anti-seizure drug because a lot of anti-seizure medications act on the GABA receptors, but it's FDA approved for migraine prevention as well. We use it off-label for neuropathic pain, especially trigeminal neuralgia, and I have seen psych use it off-label as well for anxiety and bipolar. Topiramate is a very commonly used medication because it can help you look like Miss Olive Oil here. Its number one side effect is weight loss. Patients lose about 10% of their body weight on this drug in some cases, and it is appetite suppression, so it kills your appetite. It can cause numbness and tingling in the fingers and toes. It's not dangerous, but it freaks your patients out if you don't warn them about it. The classic limiting side effect to this is that it can cause some word finding, tip of the tongue difficulty. In the Topamax is the brand name for it. Neurologists used to nickname it Dopamax because it made people feel like they were stupid in some cases, and it can cause reduced sweating, so you have to watch out for that. It's also associated with kidney stones, so if your patient has any history of kidney stones, they really should not use this drug. Botulism, Botox, as I mentioned before, originally developed for cosmetic purposes. We use it for migraine prevention. We use it as a muscle paralytic for dystonia. This is most commonly used for head tremor, the palatal tremor, and then a hereditary chin tremor. This I would caution you if you see a general neurologist. I generally defer to the movement disorder specialists who do a lot of this for essential tremor, and then sometimes the ENT specialists to do the Botox injection, because it has to be injected in the throat. It can cause dysphagia, so it can cause swallowing problems when your patients get this. They can get this painful compensatory muscle contraction in their neck and get a lot of secondary dystonia. And then rarely it can affect respiration. So physicians who are doing botulism for essential tremor really need to be well-versed and have a lot of experience using this. So that's what I have for you. I think I stayed in my 20 minutes, and I've got 10 minutes for questions. These are my girls. This is my other girl. She's remained quiet during this presentation, which I was a little worried about. So I can take any questions that people may have.
Thank you, Dr. Feldman. It looks like there's some comments in the chat from patients that have tried gabapentin and primidone and have had those negative side effects you were saying.
Okay. I think I have to this to see the chat.
Yeah. There's someone had mentioned they are on gabapentin, but according to the internet, it's not an EP medication. Propranolol made asthma way worse.
Yes, it definitely can do that.
And then there's a question, any clinical on young onset or any clinical trials on young onset?
I'm sure there are. I'm not aware of them. Dr. Halpern, do you know of any clinical trials for young onset for medications? I don't know.
Yeah, I'm not aware of any either.
I'm not either.
This gets back to the forgotten disease.
Yeah, exactly. And as I had mentioned at the very beginning of the talk, there really aren't a lot of options. You've got beta blockers, which are antihypertensives. You've got primidone, and then you've got benzodiazepines, which are addictive, and then you've got, well, sometimes topiramate, sometimes gabapentin, maybe Botox will help, but really you have 3, maybe 5 choices of what's going to help, because switching within class doesn't help. If you don't respond to topiramate, the other carbonic anhydrase inhibitors don't help. If you don't respond to propranolol, the other beta blockers don't help. So you don't have a lot of options out there. And I'm not aware of any clinical trials.
Dr. Feldman, when I see patients for essential tremor, I tend to tell them that in general, and I of course, there's other medication trials that are worth considering, but that it's all about the three Ps, and they usually already know about propranolol and primidone. And then they're wondering what this third P is. And that's, obviously with my, surgical background, that's procedure. But, I think it is important for people to realize that benzos like Xanax or Topamax, gabapentin could be helpful. And we certainly see patients who have benefited from them as well in our surgical clinic. And sometimes we feel like a procedure might be high risk for some reason. So then we bring in those other agents as well. But it was intriguing to me. I learned a lot from your presentation that the dose really matters. If you start at a low dose and there's no side effects, but there's no benefit, that doesn't mean it's not helping you. It just means you got to go up on the dose.
Yeah,
So
unfortunately.
And there actually is a question here. What is a common dose to start propranolol?
So for long acting, 60 milligrams is the common starting dose. But as I mentioned, a lot of the times you've got to get up to that 240 to see a benefit, which can be very, very challenging. And then, so long acting, the smallest dosage, the smallest preparation it's available in is 60 milligrams. And I almost always do it at bed. But short acting comes in 10 milligrams, and you can split those tablets. So for patients who already have low blood pressure, who say, I'm sensitive, I get every side effect, sometimes I'll start them on 10 milligrams twice a day and tell them to take a half. Short acting should be dosed at least twice a day. Sometimes we dose it 3 times a day. And then obviously patients with gastric bypass who can't take long acting preparations of medications, they take the short acting. So that can be helpful. Somebody else had further down, there's a question of my brother is a guitarist and he uses it as needed, the propranolol. I do have some patients who do that. I have patients who are very sensitive to anxiety, and propranolol is commonly used actually for stage fright. So some people will use it just before a big presentation, or they'll use it a performance or somewhere where they know they're going to be on a heightened state of anxiety. I have some patients who only take it on days that they work, and they don't take it if they don't work. If they're a nurse and they have to start an IV and they know their hand's going to be shaking, they'll use it on those days. So some people do take it as needed. My patients who are able to do that tend to be, I call them super responders, patients who take a very small dosage and get a robust benefit to it. And I have those patients. I have people who 10 milligrams is all they need. Some people are very, very sensitive to medications.
And there's a question, are there any concerns when these medications are used with other seizure meds in patients with well-controlled epilepsy?
So the anti-seizure class is not necessarily going to make their seizure drugs less effective. Now, primidone is it has to do with the way that they interact. It has to do with the enzymes that they kind of chew up. So primidone, when used in combination with certain other medications, can lower levels or it can raise levels. But certainly if you're seeing a neurologist, they should be aware of the potential interactions. So the only interaction is that it may raise a level or lower a level, and you've got to really be careful with checking drug levels in some of those patients. Some of my patients are able, if they have well controlled, can oftentimes come off of their other anti-epileptic medication and just be on one drug. So that can be useful too.
And it looks like Dr. Kahigas did answer one of the questions in here, if it's common to see essential tremor in legs. So it looks like there's one last question, if exercise is helpful.
So exercise is probably more beneficial in helping with lowering anti-anxiety. I don't know that there's necessarily any data, unlike Parkinson's, where there's clear data. There's been animal models where we've looked at exercise and we've actually lesioned the brain, and we've seen that there's, animal in monkey data that monkeys that exercise have a slower rate of loss of dopaminergic cells. Now that is animal models, you have to take that into account. But in Parkinson's, we definitely think and are fairly certain that exercise is beneficial for the disease. With essential tremor, there's no clear data on that. We're also not doing animal models, and it's genetic, so you wouldn't necessarily see anything when you lesion the brain. But certainly the anti-anxiety properties are good, and occupational therapy, good hand therapy can be very, very useful. And someone also mentioned CBD THC. I do have some patients who think medical marijuana can be useful. The data is actually that in general, it's 50-50. Some patients get a benefit, some patients don't. It's not, I don't use medical marijuana typically first line, or I don't use it a lot in my essential tremor patients. Most of them come back and say that it does not work. Unlike tremor for Parkinson's, which can be exquisitely sensitive to THC, there are a lot of cannabinoid receptors in the basal ganglia, and those patients will often have a very, very robust response to THC. You don't see it as much with the essential tremor patients. And again, the benefits of THC may be, for essential tremor, may be more anti-anxiolytic, like we think alprazolam Xanax is.
Okay, great. I think that is all of the questions that were in the chat here. So thank you, Dr. Feldman.